Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. And on these weekly mini episodes, we bring you bite-sized ideas for you to snack on.
Like breathing exercises, book reviews. Maybe we'll review some scientific research, or we'll share some wellness and fertility stories from our listeners.
So if you're looking for a tip or a trick related to your fertility and well-being, then you've come to the right place.
Let's dig in.
We are super happy to have back Rachelle Mallik. Hopefully you listened to her full episode. I was probably on our longer side because we just can't stop talking about nutrition, but she is a registered dietitian and owner of The Food Therapist. She is happy to come back and talk with us just a little bit more about something that we touched on briefly in the full episode, primarily that issue of like, what do you do with someone who's been told they need to lose weight for fertility treatment? So welcome back to The Whole Pineapple, Rachelle.
Thanks. Happy to be back.
And is this a common scenario that you see? I mean, is this a reason that a lot of people are sent to see you because they're told that weight loss is the primary goal?
It's interesting, when I started my practice, it was very infrequent that was why people were reaching out. A lot of people were reaching out because they were just kind of exploring how nutrition could support fertility, and they would find me through Google, find my website. As I've gotten more doctor referrals, I do get more, my doctor told me I need to lose weight before I do IVF. And they may word it slightly differently than that, but that's what they're telling me. It can be a bit of an awkward conversation when they were like, I was referred to you for weight loss. And I'm like, I don't do weight loss. But it's not to say that I can't support someone's health, right? And use nutrition to support their chances of conceiving. So weight and health are not the same thing. And unfortunately, research studies don't usually go into all of that, right? Weight loss is usually the outcome that is being looked at, or the measure of progress or success. I would really like to see more research studies looking at the health promoting behaviors and the role that they may be playing. Because typically when people do lose weight, they are maybe eating, more fruits and vegetables, or are moving their body more. But the studies don't usually tease that out. They're typically looking just at, weight loss is associated with X or not, or that the BMI alone is associated with decreased chance of having live birth after IVF, which again is not looking at anything beyond just the kilogram over meter squared, the BMI calculation. And it's missing out like anything below that. It's very superficial.
Yeah. And as we know, the BMI in itself is a flawed measurement.
Yeah, I'm going to be posting an article to my website around like why I focus on health promoting behaviors rather than weight loss for fertility clients. And I was going to link to some studies and research around the flaws around BMI, because that could be a whole other, conversation, the issues with using that. I mean, it's an easy metric, but it doesn't give you very much information. It does not assess health.
It's kind of like our AMH, right? Like it gives us some information, but not the full picture.
That is a good parallel, because it's also similar in that people use it to mean something that it wasn't ever designed to mean. Right. Just like AMH, people use it as like it's telling me my chance of getting pregnant in the future, which is not what it tells you at all. And the same thing, people are using BMI as this marker of health, which is also not what it was designed to do.
Exactly. It was not designed to do that. And that's basically what every research study uses, is BMI, and then using the quote overweight and quote obese, which is some stigmatizing language too, but that's what the studies look at.
And I know, at least in our fertility clinics, and probably similar with the ones you work at, that the reason that we are often, it's one of the few settings when we are talking about weight loss sometimes, is because many fertility clinics, if they're an outpatient surgical center, do have BMI cutoffs for anesthesia. And so the process of doing IVF does typically involve being under anesthesia for the egg retrieval. And I think that's why we end up having these conversations in so many different places. Do you know what the cutoffs are near you? I know there is variation kind of nationwide.
And I know we briefly earlier were talking about ASRM's reproduction and quote obesity committee update opinion that came out at the end of 2021. And in that, they argue that there shouldn't be kind of like a nationwide cutoff for IVF.
My sentence that I underline, which I love, is like, opponents of thresholds refer to the American College of OBGYN stance that it's unethical for OBGYNs to refuse to accept a patient or to decline to continue care that is within scope of practice solely based on arbitrary BMI cutoff or because the patient has obesity. And it's true, like you don't use this in other areas of healthcare where you're like, oh, well, you can't have this, you can't have that. But it is something that we are still using when it comes to fertility treatment.
Right.
The fact with the surgical part is oftentimes it's not the the reproductive endocrinologists that are setting that. For us, it's the anesthesiologist. Like, what risk the risk of airway obstruction during surgery. And I think that's very individual too, because I've definitely seen people that have higher BMIs that don't look like they have airway obstruction issues. And then people that maybe of lower BMI that actually do have sleep apnea and things like that too.
Yeah. And I said this to Anne before, something that always has stuck with me that I've heard from like fat positive folks and fat activists. I'm thinking of like Reagan Chastain and Nicola Salmon, who's a fertility coach out of the UK. Reagan Chastain is in the US. That they said, why is it okay to have anesthesia for bariatric surgery, but not for egg retrieval? They don't seem to have issues with that, right? And also blood pressure cuffs are meant to fit their arms. The chairs are more accessible. Like the built environment is more accessible. And I'm using fat in a very neutral term.
Yeah, that's like the one area in medicine that's built all around being accepting of fat bodies, but it's because you're trying to change the body.
And I think for us, it's an outpatient facility, so they're not connected to a hospital. Because if you're connected to a hospital, like we do refer patients to facilities that have ORs that are connected to a hospital.
Yeah. And I think if a patient is told, they need to lose weight, again, this is kind of words I got from Reagan Chastain, is like, what would you tell somebody in a thin person with the same issue? And if it's accessible to them, and I mean that from a, money, time, distance traveled, to go to a clinic where they could do that. Because in that committee opinion, they talk about that hospital-based series of IVF retrievals that were done in BMIs of in the 40s and some above 50, and where could be done safely. Their kind of summary here is, on the basis of available evidence, there's no medical or ethical directive for adopting a society-wide BMI threshold for offering infertility treatment. Rather, there's considerable evidence arguing against such a policy.
I think also it plays into the fact that everything is risk benefit, and a lot of people still see fertility treatment as this elective, right? So in that study they're talking about, they're saying what they found in that study is that you only had less than 7% of the time did you need to have an oral airway. So they're kind of saying there's this really low risk of it even becoming an airway issue. But people are going to argue from the other side, well, a 7% risk is too high for something that's elective. People aren't quite realizing how important fertility treatment is for people. And so there's not really a truly equal comparison to do nothing.
So one of the other issues that I think of like recommending weight loss without knowing that person's history is like, how do you know they're not currently dieting? How do you know they don't have a history of or a current eating disorder? How do you know they don't have a dieting history of like yo-yo dieting, or weight cycling is what it's termed, medically or in like research studies, because we know that that's harmful for health. Weight cycling affects metabolic health and overall health. We know eating disorders are correlated with menstrual irregularities, and weight stigma has also been correlated with inflammation in the body. And like, are we controlling for those things? Or are we just seeing, again, BMI without any other information about that person? And then making these assumptions, see BMI is the problem versus all those other factors that could be at play here.
I think the challenge too, though, is that, egg supply and age, all these things are on a time scale that's different than we're ever going to make societal changes in terms of your anesthesia group, I think every fertility clinic needs to have options available, right? And it's like, but if you're the individual patient and you're in an area where really the only clinic around you has this cutoff limit, your reproductive timeline to be able to do fertility treatment is probably shorter than the time it's going to take to finally push an anesthesia group to reevaluate their BMI limit. And that's what's so hard. Right. It's like we need to kind of be addressing these societal level things, but also how do we give care to the individual in the meantime?
And we talked about this in our weight loss medication episode, is that not everyone has the time to wait to lose all this weight to do fertility treatment. They might have diminished ovarian reserve, or, being perimenopausal, where we really have a time limit to doing these things.
And the 2021 systematic review of randomized controlled trials, basically their conclusion was that weight loss, combined exercise and physical activity improved rates of live birth, of clinical pregnancy and live birth, I think was the outcomes they were looking at. But the two large trials that were included in that did not demonstrate that benefit when people were offered immediate access to IVF. Or to ART. It's interesting when you read conclusions and you're like, if you dig into what the discussion talks about, or I'm like, does it say that? Because these very small studies with high attrition rates that people were dropping out of showed this benefit, but these ones where people were able to go right into IVF didn't. And I'm a dietitian, so I'm not going to say that like nutrition doesn't matter. They've also shown that with some, dietary changes and movement that people had higher natural conception rates. But there's a lot to consider on the person's age and like maybe they being informed, right? You could work with a dietitian, you could work on some of these health promoting behaviors if you're 25, 30, maybe 35, depending again on all the factors involved and why you're dealing with some fertility challenges, considering that as opposed to like withholding IVF treatment until you're able to lose weight.
And you brought up that really good point earlier too about rebound weight gain, because many people have to do IVF more than once.
Yeah.
If you go on something very unhealthy and you go and you just barely make it and you have your first cycle, and then while you're waiting to find out if you have any normal embryos or this and that, can you imagine then finding out, oh, I'm going to have to do this again, and now I've put on, this amount, and that's got to be such a defeating situation to be in, and you haven't done really anything to improve anybody's health.
Yeah.
I've had patients who have conceived and they were in their first trimester and unfortunately had a miscarriage and then want to go back in and do IVF again, and now their BMI is higher. Or even having that discussion when somebody has had a miscarriage and maybe for their IVF cycle they were under 40, that cutoff for anesthesia, and now they've had a miscarriage and we're talking about options. And if we have an outpatient facility and the anesthesia team has a cutoff for BMI of 40, but they're above 40 now. Now you can't have like a DNC to treat your miscarriage. That just is really, really a very difficult conversation to have.
Yeah.
Well, I think it's interesting in the guideline too. I mean, we talked a little bit in the full about considering international perspectives too, as much as we may bash on the US and we're talking around these cutoffs of 40, like they mentioned here, how Australia and New Zealand's college has recommended BMI threshold of 35, and New Zealand limits access to public funding for IVF unless the BMI is less than 32. So you're talking about not necessarily the access to care, but the financial, they're basically just saying, we're not even going to cover fertility treatment for you unless your BMI is less than 32.
You think about like ethics and justice, that just does not sit right with me.
Do we know about Canada?
Let's see. It says a survey of Canadian IVF centers found that half of programs declared a BMI threshold, but it ranged from 35 to 45. And the interesting thing is, at least in this survey of Canada, the most frequent reason given for a cutoff was concern about obstetric risk. Because I don't feel like that's something that we deal as much. I mean, that was one of the early things, and I feel like there's been more research.
Remember when they recommended like seeing a maternal fetal medicine specialist for a BMI of 40 above? And most of the MFM providers are like, if you send somebody to them that is like BMI of 40, they're like, why did you send this person to me?
Oh, Ruby, I've been here a long time. Our guideline used to say 35. And I remember starting and being like, wait, am I supposed to be getting them an MFM consult? And they were like, oh, really? Does it say that? I'm like, it says anesthesia and MFM. And then they revised it to say above 40. And then we still weren't doing it. And then we finally took it off.
Interesting.
And the hard part is there's no easy solutions, right? Like, again, you can be lobbying. Rachel and I were talking before we were recording. I brought up how, working in labor and delivery and then working in fertility and going back to school to get my master's and then being back in the hospital. I was shocked at how little we had changed views of anesthesia there in terms of like, once you're in labor, if there's even the possibility you might be having a C-section, like, sorry, nothing for you, suck on those ice chips, NPO. And there's been so much research to show that, you can have food and drink, and other countries do that very differently. But, anesthesia is by nature a very risk-averse group. And so it's a very slow process to try and convince hearts and minds about stuff, and you need a lot of data, and it's hard, I think, to collect that in a fertility population because there's such a range. So many centers, some are in hospitals, some are out, some are large, some are big. There's no like centralized reporting that's required necessarily for, at least in my mind, for anesthesia complications. Does SART required? I mean, I don't think it's one of the fields that we do. We talk about birth outcomes, but we don't talk about It's so rare to have a bad reaction as part of an egg retrieval that it's one of those things I don't think anyone's even looking at.
Well, that would just really inform our care too, because then we would have the evidence to back up like, this is the actual risk of anesthesia complications. Again, we're running into the risk of using BMI as a measurement tool.
Right, because then we see this association, right? People in all body shapes and sizes deal with infertility, and people in all shapes and sizes deal with eating disorders. So recommending weight loss for fertility when it's something that affects people of all body shapes and sizes, and that if you don't understand the person's eating history or eating disorder history, and there's higher rates of eating disorders and disordered eating in people who seek ART, specifically people with ovaries, then I just see that could be really harmful, right? It's not looking at the whole person. It's looking at like the weight itself as the problem.
So what do you do then when someone's referred to you? And this is why they came to see you, because their clinic says they've got to lose 20 pounds to do IVF. Like,
yeah,
get on the phone and call them. Can I talk with the anesthesiologist?
Yeah. I've definitely talked to some doctors about my approach and why I do that. And I think that's why I'm working on this lengthy blog post for my website, is not just for potential clients or current clients, but also for like doctors, because they do like to be evidence-based. And like, is the study controlling for weight bias? Is it controlling for weight stigma? Is it controlling for a history of weight cycling and how that makes may show up, and usually it's not. But so anyway, when I'm working with clients, or at least they've called me and are considering working with me, I explain my approach, and it often resonates with people because so many people have already dieted. And the step one of intuitive eating is reject the diet culture, that another great diet isn't just going to come along. And I'm offering health promoting behaviors that are sustainable, achievable, and may affect their weight. We just don't know which way it's going to go, right? Your weight could change as a result of those health promoting behaviors. We just don't know. So it's not for everyone, right? If it's like, this is the only way I can proceed is if I lose X amount of weight, then I may not be the right fit for them, especially if they're on really a time constraint, versus like if they're willing to give it a try and see how they respond to it.
It's interesting for me, like thinking about it, I feel like we are probably the worst in terms of our health promoting behaviors for the people that are right on the limit. Like when people have a BMI of 45, I think we're just kind of like, okay, so let's talk about hospital-based and here's how I can do this. But it's the people where we're like, well, you're so close. And then that feeds into that idea of like, oh, well, if I just, cut out this and dehydrate myself and come in and take off everything, like that's going to just make weight. Exactly. And I've had patients do that. I've had people come in on their suppression check date and be like, hang on, I'm going to take off my sweater and my boots and all my layers.
Yes.
And it's hard. I don't have a good answer, but it's interesting. I think we push the worst behaviors on people because they're close to achieving something. And that's like probably really a bad way to go about it.
This is not to bash anesthesiologists because our anesthesiologists are fantastic.
Yeah, you want to be comfortable during your egg retrieval. That's another crazy thing to think of in the olden days when they sometimes wouldn't, you just have to lie there because people have asked that. They're like, can I be awake then? Can I have it here?
And some places still do just local anesthesia, but our anesthesiologists are wonderful. And I actually, our group also works at the hospital I delivered my first son at. And I remember I was being induced. I was going to try to do as much, natural as possible, but Pitocin is and I went from like 0 to 60 really fast. And so they were like scrambling to find an anesthesiologist, and in walked Doug, one of my favorite anesthesiologists that worked at SRM. And I was like, Doug, I'm so happy you're here. I don't even care if you're going to look at my butt.
That's true. No one loves an anesthesiologist more than a woman in labor.
But yeah, and then it was so funny because one of our other anesthesiologists came in. They were just like having a conference behind me. I'm like, oh man, it was funny.
When we're kind of, people are desperate, right? And they're going to do what they think they need to do when they're already struggling with infertility and then that body shame and stuff. And I'm just like, at what cost? Like, what behaviors are they engaging with? How does that affect their mental as well as their physical health, right? You're trying to have a baby. And if you're like just significantly restricting your body from nourishment, I was looking at one of the studies that was considered a very low carbohydrate diet in this systematic review that included this study of people on 400 calories for 6 to 12 weeks.
Oh.
I'm not okay with starving people in the name of shrinking their body. I cannot imagine eating 400 calories a day for a month and a half to 3 months. That's barely a breakfast.
You have no energy to do anything. Like you need to be moving your body too. So you're just,
Yeah, like how do you function?
Yeah. And I think that included exercise too. And I'm like, oh my God, those things I have some hesitations. Obviously that's very, very restrictive, but that's included in these like trials, right? Of like how we get people to lose weight in order to do their IVF. And that's really problematic. There's a lot that goes into it. BMI cutoffs are a reality for some folks. And we talked in the beginning about potentially some options. I mentioned Nicola Salmon, that fertility coach that's in the UK. She actually has a page on her website around like quote unquote fat positive fertility clinics. And it's kind of like crowdsourced by people's experiences of like where they haven't been shamed about their weight, where they have a cutoff that might be like 45. So, that may be an option. It's obviously not an option for everyone. But, if you're considering, I provide nutrition counseling, not weight loss counseling. So if you're considering like wanting to support the nutrition for an IVF cycle or for fertility in general, then I'm here for that. But if weight loss is like the end all be all on what is your understanding of all this information, that's what you need to do, then, I may not be the right fit. But I think in my experience, the people who have learned more about my approach, learned a little bit more about intuitive eating and health at every size are on board with that because they have that long history of dieting. They're like, yeah, I want to try something different because it hasn't worked. I mean, the research shows, fertility studies as well as just general studies, that most people regain the weight they lose. 1/3 to 2/3 gain more than they lost. And if you compare that to a medication, medication would not be on the market, right? I've heard that from other non-diet dietitians, like the efficacy rate of weight loss interventions, if it was a medication, would not be on the market. So just think about like the sustainability of it. What happens when they are pregnant? Are they going to be able to maintain those kind of behaviors still? And if that weight gain becomes even more significant in pregnancy, I just think of what happens next. I think a lot few steps ahead. And I know people are very focused on like what happens right now, but I also like to think more broadly than that.
One other thing that I hadn't thought of before in terms of just like trying to look for silver linings in bad situations is I know at least here and also nationwide, like there is such a backlog of interest in fertility care post-pandemic, and the wait times to be able to do IVF are so much longer than they used to be. But that also gives you a little bit more time to take this approach and just see what happens, right? You don't have this, I'm supposed to start my injections in 3 weeks and I've got to be below a certain number. Like if your start date isn't for 4 months, then maybe you could take a month or two and really, work on all these approaches and see what happens and see how you feel. And then like decide, what the best next step is for you. So I feel like as much as we talk about aging and ovarian reserve, like it's still not like a month by month plummet. And we want people to like take this slightly longer term view, which as you said is really hard because they wanted to be pregnant a year ago, but it's setting you up for such a better pregnancy as well, which you mentioned.
Next, you bring up a good point that came up in conversation with someone else the other day around if your fertility clinic's booking new patient appointments in January, this could be your time to refer them to a dietitian. Like, have you considered some lifestyle things you may want to work on, right? Not forcing it on anyone. It is not an obligation to see a dietitian, but it should be an option if you want it, right? For those clients that are like feeling like, what can I do right now? I'm just sitting here waiting. That could be a great time.
A focus on nutrition is never going to make anything worse when it comes to fertility treatment. Whatever fertility treatment you do, it's still always better to go into it healthy.
And just in life, it's kind of like mental health therapy. I'm like, I kind of just want a nutritionist just to like check in with every once in a while, you know?
Absolutely. Right. And I think, especially with the non-diet weight inclusive approach, because I do think there unfortunately can be some negative effects of some nutrition interventions, right, depending on what they are.
Right.
But if you're kind of coming at this from this really nourishing, sustainable behavior change, providing some motivational interviewing, understanding where the person is coming from, then yeah, it's a great option. And to your point, Ruby, I think it's great. Like, even if someone doesn't have like acute issues or some major medical situation going on that they really should see a dietitian, if they want to work on that, then that's a great time for them to just have an assessment, right? There's some folks that I'm like, okay, you're really in a good place, just keep going. I'm here for you to ask questions. Like, maybe we'll shift some things about your supplements or add in this here, but like some people don't need this major overhaul. And again, I'm not even a place from an overhaul. I'm like, meet somewhere where they're at and make it achievable, incremental, steps towards bigger goals.
This is also good. I have to go have a healthy snack now. I'm very inspired. I'm going to balance my proteins and I have my apple and I'll have something with it.
Yeah. I know I had some grapes and cheese before this.
It is that time, and it is about that time.
It's your 3 o'clock snack time. See, I'm like 5 over here, so it's much closer to dinner time. So I think I'm all right.
It's getting closer to dinner. Well, Rachelle, tell us again where we can find you.
You can visit my website, rachelmallik.com. That's RACHELLEMALLIK. You can book a discovery call or an initial consultation there. You can also sign up for my wait list for a forthcoming fertility course to just get the basics around nutrition for fertility.
I definitely can't wait to find that.
I know, me too. You might see me and Anne popping in there.
Right? Just like it's like a resource, right? You can just kind of Control F and search for what you need.
And she is Rachelle Mallik on all the social things.
Yep.
And we will link these in our show notes as well, so you can find them.
That's it. Thank you so much for your time, Rachelle.
Thanks for having me.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.